Hello, my name is Julian Hartley, Chief Executive here at Leeds Teaching Hospitals. Welcome to Friday Report Out. I'm delighted that despite the challenges of COVID-19, we are reintroducing Report Out and doing it in a modified way. I hope that many of you are able to join us live streaming on YouTube. Just to say, if you have comments on any of what you're about to hear and see, please do feel free to add comments or questions on the YouTube channel in the chat section, in the comments section. That would be great. Leeds Improvement Method, Friday Report Out. We've got Dr. Andy Brooks, who's Clinical Leadership Fellow and Paediatric Registrar, and Andy's here to talk about his improvement work. Andy, over to you.
Thanks very much. So thank you, Julian. So as Julian said, my name is Andy Brooks. I'm a Paediatric Registrar, and this year I've been a Clinical Leadership Fellow working here in the Leeds Children's Hospital. And today I'm going to be reporting out on an improvement project which I've done alongside a number of colleagues in trying to improve our postnatal readmissions process. So this is a pathway which was set up mainly around the CAT unit, but also involving the neonatal unit and the postnatal teams involved in the midwifery leads and the postnatal wards. Just as a bit of a background, the CAT unit, or the Children's Assessment and Treatment Unit, sees around 14,500 patients a year. And at the extremely busy times, we can see roughly around about 80 to 90 patients per day. We receive referrals from GPs, from A&E, from midwives, and also we have a number of patients who are on our direct access list because they have underlying medical conditions. The CAT unit at the moment, as it stands, comprises of 2 bays of 6 beds. We just have 2 medical assessment beds for more urgent cases, which we call our Puma area, and we have 1 breastfeeding room and 1 observation room, both of which are side rooms. But as you can imagine, with the number of patients we're seeing a day, it can get extremely busy at times. We see patients from anywhere from a day of age all the way up to 16 years of age, and indeed during the COVID outbreak we've been seeing patients all the way up to 18. So again, that's put quite a lot of pressure on the CAT unit. In terms of where this came from, we see a significant number of babies admitted and referred to the CAT unit. And a lot of those babies fit in in the first sort of 7 days of their young lives. The majority of these referrals are around weight loss and jaundice, and in generally well babies, so they don't necessarily need the acute medical attention of an inpatient paediatric ward. We also see that they may present with feeding difficulties and potentially can be dehydrated secondary to this, requiring more feeding support, and that may well be just additional support from the midwives, but it may well also include NG feeding and IV fluids in the most severe cases. Of course, we also see the more sick babies presenting with sepsis, potentially bronchiolitis, as well as sort of vomiting, abdominal problems and other surgical complications. So it was identified during one of the busiest times of the year. So October, November 2019 were some of the busiest months that the Children's Assessment Unit have ever seen. So at that point it was decided that we needed to try and look at how we could improve our number of admissions, especially for these small babies who are particularly at high risk, and how we could try and reduce those numbers and also improve the patient experience for these new families. So the babies on the CAT unit, obviously if they're presenting within the first 7 days, they're at significant high risk of developing infections, and on the CAT unit there are lots of older children. These older children often are presenting with infectious diseases, coughs, colds, viral infections, all of which potentially vulnerable little babies can be susceptible to. There is, as we've discussed, a slight lack of space to feed and to provide the care that small babies need, such as nappy changes, etc. And because there isn't the space on the CAT unit to do this, parents end up having to do this in the corridors or in an open bay where it's difficult to find that privacy. We also, because of our how busy the area is and how busy the CAT unit can get, you can have to wait a number of hours to be seen, and it can be extremely noisy, which again isn't ideal for a newborn baby. And equally, it has a significant impact on new parents. Obviously, this is stressful time for parents anyway. And if you're having to spend your afternoon or evening surrounded by 20, 30 other children who potentially are unwell, making a lot of noise and putting your child at risk, it's not ideal. We also recognise that a lot of our babies who were admitted through the CAT unit and then required inpatient admission for further support ended up going to a paediatric ward. We've noticed that there has been significant changes with how we look after our postnatal babies, and if we can manage these babies on the postnatal ward, they can get a significantly better outcome in terms of their experience, but also their parental experience as well. The amount of support which you're able to offer on the postnatal wards is much improved. The breastfeeding support, both offered by the midwives and the breastfeeding coordinators, is available on the postnatal wards. There is much more peer support on the postnatal wards because you're surrounded by other mothers who are in a similar situation, other families who understand what exactly the challenges you're going through. And also, if these babies are admitted to a paediatric ward, they are required to be in a side room to protect themselves, but this does lead to further isolation, and it also often means they have to be put onto an outlying medical ward or even a surgical ward because of the availability of a side room on the paediatric inpatient beds. So we came up with some aims to where we want to try and improve and went through a number of PDSA cycles. So the aim was to try and decrease the number of patients coming through the CAT unit unnecessarily. We wanted to increase the number of babies going to the postnatal ward rather than the paediatric ward, if that was indeed appropriate. And we also wanted to offer the midwives in the community who are ringing for advice, specialist advice. So being able to speak to the people who are going to be able to give them the most accurate and expert information. And we felt that that was best supplied by the neonatal team, who obviously look after newborn babies all the time. This also aligns with the British Association for Perinatal Medicine guidance. So they suggest that babies within the first few days who are required to be readmitted for feeding support or non-haemolytic jaundice, so physiological jaundice, which is very common in newborn babies, are treated on a postnatal area rather than within a paediatric setting. And this is for all the reasons that we've previously discussed. So how do we go about doing this? Well, we were extremely lucky that we had a brilliant team working alongside us. We set up a multi-speciality meeting, so that involved the paediatric team, both from the CAT unit and the inpatient units. We also met with the neonatal team, so that was led by Dr. Hannah Shaw, as well as some of her A&MP colleagues. And we met with the ward matron and midwifery lead for L36, which is the postnatal ward at the LGI. Following this, we came up with a number of strategies of how we're going to try and improve this, and these are outlined here. So the neonatal team agreed to take all community midwife calls between the hours of 8:30 and 4:30, Monday to Friday. They agreed that all babies who did need assessment for jaundice and also required admission would go to the postnatal ward where appropriate. The other babies who required feeding support as an inpatient rather than being managed in the community would also be able to go to the postnatal ward rather than having to go to a paediatric ward. And to try and improve our breastfeeding information and support in the community midwives offered to create some more information and also provide better support through their links in the community. And also we introduced the use of a billy flash. And a billy flash is essentially a small machine which enables the jaundice level of a baby to be measured without needing to take a blood test. It's obviously not quite as accurate as doing the serum blood sample, but it does supply a really good estimate of what the level is. And if it isn't at a certain level, the baby therefore doesn't have to go through the invasive test of having to have a blood test done. So these are some of the results. So October, November was where we initially started from and where we was set at our baseline. So you can see that in October and November, the CAT unit was seeing roughly 38 patients per month. Of these, there was a combination of both medical patients, which accounts for around about 11 or 12, and then also feeding and jaundice babies. So following our intervention, which started in January 2020, we were able to re-audit the results and see how many patients were coming back during sort of February, March and April. And you can see that the number of admissions have significantly decreased. The medical reason have roughly stayed the same, which is what we would expect, because those babies who are medically unwell still obviously need a medical opinion. However, those babies being admitted for feeding and jaundice issues has significantly decreased. So from around about 26 and 27 down to 15 or 16. We also noticed that those babies who were actually admitted into an inpatient bed following review on the CAT unit had increased slightly, which is exactly what we want. We want to be seeing the babies who need to be in hospital and not seeing babies who potentially could be managed in the community where possible. So this just gives a graphical representation of that data. So I think the bar charts show quite significantly how the number of admissions through the CAT unit have changed. We will talk a little bit more about the impact of certain changes that happened around February, March on the results, but I certainly feel that there has been a significant improvement here. The other thing we noticed was that babies who are being referred for weight loss issues generally fitted into the category of a weight loss percentage between about 12.6 and 15%. Currently, our guidance is that all babies who have a weight loss of more than 12.5% require a medical review. This is obviously why we're seeing significant proportions in this category. However, some recent research and guidance is slightly changing to say that this weight loss percentage could be increased to 15% if indeed the right information was provided and the community midwives making that assessment were happy with the clinical condition of the baby. So that you'll see from these results that if that was the case, then we would be able to reduce our admissions further by at least sort of 50%. In terms of where the babies were admitted to, we haven't made significant gains in this area, unfortunately, at this stage. So you can see that from October and November, around about 30% went to the postnatal ward, and this only increased ever so slightly to 31.3% after our interventions. However, I think one of the significant impacts of that was because of COVID, and unfortunately, because of the impact of that coronavirus has had, it's meant that the availability of beds on the postnatal ward has been limited, and also they are very limited with a number of side rooms, and they're being exclusively used for patients with confirmed or suspected coronavirus. So during this time, the majority of the babies were being seen on our cold CAT unit assessment area, which was co-located with L40, one of our paediatric inpatient wards. And you can see that there's been a significant increase in the number of patients who are staying on L40 and being admitted to L40 as necessary. And I think that is an impact of the coronavirus outbreak. So in terms of sort of a summary of what we just discussed, so we've certainly seen an increased number of calls going to the neonatal registrar and ANMP. We've gone from having no service there at all to now the 4 or 5 calls a day being taken by the paediatric registrars on the neonatal unit. There's been a significant decrease in the number of admissions for weight loss and jaundice, and this has been nearly up to 60% from where we started, which is great. We've also seen a significant increase in the number of babies who are actually admitted because of weight loss and jaundice, suggesting that those referrals that are coming through are much more appropriate than they were. As mentioned, we haven't seen a significant increase in the number of admissions to wards, but we have recognised why this may be the case. So just in sort of discussion and summary of what we've done, I think this has shown excellent collaboration across 3 different teams. So we've worked really well with the paediatric team, the neonatal team, the midwifery team, both in the hospital and in the community. And everybody's been extremely supportive of what we're trying to do to improve patient care and patient experience within the Leeds Children's Hospital. We've seen a significant decrease in the number of admissions with no reported adverse events, which suggests that everything we have done has been successful and we've not seen any significant problems associated with it. And it does give us a chance to try and improve this as we go forward. And as discussed, although we haven't seen the improvements in the number of admissions to the postnatal ward, we do see that COVID has had an impact there, and we've looked at how we can try and improve that going forward as we come out of the pandemic. So where do we want to go in the future? This is an ongoing project, and I don't think we're ever going to get to a stage where we're completely happy with the situation. And as with all improvement, there's always areas you can try and improve further. So eventually, once you get to the stage where the neonatal team are taking all the calls from the midwives, so as I mentioned, at the moment it's just during daylight working hours, but we hope that that will continue as the provision for care improves. We're able to do that over the weekend and into the evenings. The CAT unit is due to relocate in October of this year over to ward L37-38, which will be immediately adjacent to L36, the postnatal ward, which hopefully should have a significant improvement in the working between both the midwifery teams, the postnatal teams, and those babies coming to the CAT unit for review. We're also looking to review the criteria for readmission, so the neonatal team are looking at whether we can increase our weight loss referral criteria up to 15%, which, as discussed, would significantly decrease the referrals even more so. And in terms of where we want to be in the future, we want to look at trying to develop home phototherapy for babies who have jaundice. This is something which has happened in other hospitals within the country and has been successful in the pilots. So we hope that we can try and introduce that here. And also, as the number of advanced neonatal nurse practitioners increase, we hope that we may be able to provide an outreach clinic for these babies. Rather than them having to come into hospital, they could be reviewed in the community and managed in the community rather than having to come into hospital for medical reviews. So that concludes the discussion. As I said, it has been a huge collaborative effort between a number of different teams, and these are some of the people, not all of them, but some of the people who have been integral to everything that we've done. And hopefully we will continue to work together as we try to improve in the future. So I'd just like to say thank you very much. Thank you for inviting me this afternoon, and if there are any questions, I'm very happy to take them.
That's great. Thank you very much, Andy. Really good, really positive and powerful presentation there, I think, in one of our obviously key areas where we know, as you said, that we have got the opportunity to develop that further with relocating to a bigger space and taking that forward. So really good to hear that. So I'm just going to check in if we've got any questions or comments. If not, and of course this video is available for viewing, and I'm sure Andy will be happy to take any questions or comments. But I think I'd want to ask, I think I want to start by asking you, Andy, what were your biggest learning points from this piece of work?
So I think what came out of it was how willing people were to change. I've done a number of projects this year in my leadership fellow post where change has been a little bit more difficult to establish. And I think both me and Avinash Tantri, who's our clinical lead, were extremely pleased with how willing people were to change and willing to go above and beyond what's expected to improve things, improve experience for the patient. So I think that's been excellent. And I think also, obviously, everyone's been having to deal with the consequences of COVID. Yeah. And not least, the number of admissions coming through the children's unit has changed significantly. But it's looking at how we can try and do more to keep patients in the community rather than bringing them into the hospital where potentially they could, at the peak of it, certainly have been at risk. So we've certainly developed a lot of pathways which are trying to develop our community working, managing patients in the community, and therefore decreasing the number of patients needing to come to hospital.
That's great. And how did you find applying a sort of continuous improvement, Leeds improvement method tools to this challenge? How did that help you see it perhaps in a different way, or help you in sort of diagnosing and understanding the challenges?
So I think having the data was extremely important in this area. So I think for a number of years people have recognised that the number of babies coming through is quite significant and their experience isn't great, but we didn't have any data to say how many potentially could be managed in the community or how many are actually going to the paediatric ward versus the postnatal wards. So having that data and being able to get that on a monthly basis, and I'm still getting all the data coming through now, we can see on how things have changed throughout the year. Obviously, within paediatrics, there are peaks and troughs in terms of our number of admissions, but the number of readmissions for weight loss and jaundice generally stays the same throughout the year. So the fact that we've had such a significant decrease obviously means that something has been effective and something has worked. And I think just having that data to support us also allowed the other teams who we were working with to say, we can provide this extra care, we can provide a better experience for patients, and it's not going to significantly increase your numbers.
Yeah.
In terms of the admissions to the postnatal ward, it's around about 10 to 12 per month, which isn't a significant number of increased patients considering the number of patients who come through. So once the postnatal team were able to see that, it was much easier to persuade them that this was definitely the right thing to do.
Terrific. Really good. And it was great to see the emphasis on collaboration and across 3 CSUs, and really good to hear that everyone was really motivated to get involved in the project and help support that and focus on the value that we can add for our babies, patients, families. And actually the results are great to see, and I'm sure there's plenty there to build on, and your next steps, I think, set out a good agenda for taking this forward. So well done, and please pass my thanks on to everyone involved, because I think it's a really good example of the Leeds improvement method.
Brilliant.
So I'd just like to say a big thank you to Jimmy and the KPO in relation to all of this work, and also of course for this to our brilliant medical illustration team who are managing to do this. So really good, and please do tune in to these report outs. We will have this available, so if you do have any questions or comments for Andy, I'm sure we can feed those through and get those back to you. That is it for today. Thank you very much for joining, and see you next time.